Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hi, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I am Dr. Dan Mingle, and I'm here to answer your questions, the best of my ability.
So this episode is going to be a little bit different today. What do you have for us, Dr. Mingle?
Well, we're getting a lot of questions, Kyle, and hearing a lot of confusion out there about the APM performance pathway and what to expect in 2025. So I'm devoting this episode of Ask Dr. Mingle to a logical review of the possible outcomes of final rulemaking and your options under each of those scenarios. First, I'll put it into context. The proposed rule for the 2025 version of Medicare's Quality Payment Program was released in early July 2024. The comment period closed for the rule on September 9th. I'm recording this on September 20th of 2024, roughly 6 weeks before the final rule is due to be released on November 1st. The APM performance pathway, that is the APP, mostly impacts groups participating as accountable care organizations, or ACOs, in Medicare's Shared Savings Program, that is the MSSP. Successful submission of data under the APP is required for MSSP ACOs to receive any shared savings that they have generated through the program. It has a smaller impact on other alternative payment models in Medicare's Quality Payment Program, where it is an option for MIPS-eligible clinicians, but not required. And it's not required in any other program and not available to anyone in traditional MIPS. Since the beginning of the MSSP, quality reporting has been required. Groups generating shared savings are required to meet a threshold quality performance level to be eligible to collect any shared savings they have generated. Until 2021, the CMS web interface was the one method approved and required for MSSP ACOs to collect and submit quality performance data to Medicare. The web interface in ACOs is predominantly a manual chart abstraction process. It involves a 248 patient sample for each of 10 measures, with the results tabulated and submitted on a spreadsheet to Medicare. Now, 248 patients times 10 measures equals 2,480 patient charts at worst. It's generally better than that because most patients sampled have multiple measure eligibility. That is, many of the measures share the same eligibility requirements. So one patient chart might give you several measures. Manual chart abstraction of the web interface took a lot of the complexity and difficulty out of reporting for MSSP ACOs. The typical ACO is a partnership of disparate, distinct, independent tax ID number practices using distinct, disparate, isolated EHRs, providing for the healthcare needs of a shared community of patients. The data does not come together easily for all patient, all payer reporting that the MIPS community has been delivering since 2017. The quality performance sampling done for the web interface method is at best an estimate of the quality of care for only the traditional Medicare population. Medicare, with the intention of bringing ACOs up to the all-patient, all-payer quality measure standard to which MIPS participants are subject, in 2021 reorganized the APM performance pathway around two new options for MSSP ACOs to collect and submit their data. They could continue to use the 10 measures of the web interface, or they could choose to submit a smaller set of 3 measures as MIPS clinical quality measures or as electronic clinical quality measures, or ECQMs. After a few delays and some additional restructuring, the option to use the web interface is due to sunset in 2025 after the 2024 quality submissions are complete. So for 2025, submitted in 2026, one will have to use a method other than the web interface. Now, MSSP ACOs have objected to the difficult and expensive task of retooling to all-patient, all-payer measurement. Medicare's responded by introducing a bridge method called Medicare CQMs. It's precisely based on MIPS CQM measure specifications, but limits the patient population to Medicare Part B beneficiaries. It's a measurement of quality like MIPS participants have been subject to, unlike the estimate by sampling technique to which web interface users have been subject. Unlike MIPS CQMs, which is all patients of all payers, Medicare CQMs are all patients of only one payer, traditional Medicare Part B recipients. Medicare CQMs is described as only a temporary collection method to ease the transition from manual chart abstraction for quality sampling of the web interface to the all-patient, all-payer measurement of clinical quality measures of some variety. Today, as we look ahead, after release of the proposed rule for 2025, there are three distinct paths from which Medicare will choose and announce in the final rule for 2025. First, Medicare will finalize the rule as proposed. This will sunset the web interface option as scheduled after the 2024 performance year submissions. It will continue the eCQM option of the APP. It will continue the Medicare CQM option newly added as a temporary choice for the APP, and it will discontinue the MIPS CQM option for the APP. If Medicare follows this option, all ACOs will need to prepare for a future day when eCQMs are the only option. We don't know when Medicare CQMs will be sunset, but it could happen in any future annual rulemaking cycle. Second option, Medicare will postpone the sunset of MIPS CQMs for the APP. In this option, they will sunset the web interface option as scheduled after the 2024 performance year submissions. They will continue the eCQM option of the APP. They will continue the temporary Medicare CQM option, and they will temporarily continue the MIPS CQM option. Now, from the perspective of a qualified registry, I view MIPS CQMs and Medicare CQMs to be fairly similar. There are some short-term advantages to Medicare CQMs, but the reality is, like in the first option, we'll continue to live year by year under the threat of Medicare and MIPS CQM sunsetting for ACOs. Under both that first and that second option, all ACOs will need to make substantial investments into an eCQM capability for that undetermined date in the future when both MIPS CQMs and Medicare CQMs join the web interface in its sunset status. Medicare's third option, and the best possible option from my perspective in the final rule, is permanent cancellation of that proposal to sunset MIPS CQMs. I don't see any advantages of eCQMs that justifies for you the expense and effort of the transition. And I don't think it as thoroughly, as accurately measures performance as does MIPS CQMs, and can never be as good as MIPS CQMs for reasons I can get into in another program. Now, that's how things look to me today as we anticipate the November 1, 2024 release of the final rule for the Quality Payment Program for 2025. Now, many of our clients and friends are confused. They're wondering what to do and what action to take in the face of uncertainties in the rule. Now, I think a logical look at the options shows one clear path forward that does not need to wait for the final rule and will put an ACO in the best possible position in any of the three rule futures. First, if Medicare finalizes the rule as proposed, if CQMs are discontinued, you'll have to report in 2025 and later years either eCQMs or Medicare CQMs. You can expect Medicare CQMs to eventually be discontinued. They are not the all-patient, all-payer quality measurement that Medicare intends. you're not ready for ECQMs. If you're not already doing them or well underway in your preparation, you're not going to be ECQM ready for 2025. For 2025, you need to engage a competent qualified registry vendor like Mingle, who will help you with Medicare CQMs and convert you to ECQMs when ready, helping you in the meantime get ready for those ECQMs. The second option, if Medicare postpones the end of MIPS CQMs, you can expect MIPS CQMs and Medicare CQMs to end in some yet to be determined year in the future. It might be the same year, and it's in no way certain which will be discontinued first. But just as I described, if you're not already underway to doing ECQMs, you're not going to be doing them for 2025. For 2025, you need to engage a competent qualified registry vendor who will help you with Medicare CQMs, convert you to MIPS CQMs when ready, help you build your ECQM platform, and convert you to ECQMs when ready. Now, the transition from Medicare CQM to MIPS CQM to ECQM is a logical and natural progression, and we can help make that so for you. And although there's a lot of preparation and investment needed by the healthcare system, from the registry vendor point of view, that progression is managed through two simple switches. From Medicare CQMs to MIPS CQMs, it involves the Is Medicare switch. In collecting your data, we import an indicator of the patient's insurer and mark whether or not it is Medicare Part B. For Medicare CQMs, we flip the switch to only analyze the Medicare Part B patients. For MIPS CQMs, we let all patients of all payers contribute to the analytics. So for us, just a simple switch, even though there could be a fair amount of infrastructure necessary for you behind it and some of the consequences of how hard manual override of faulty measurements is done. Now, from MIPS CQMs to ECQMs, it involves the electronic source switch. We keep track of the source of your data, and to reduce an ECQM, we eliminate all data that does not come from a CEHRT source. And the third option, if Medicare permanently cancels the plan to end MIPS CQMs, this, in my opinion, is the best possible outcome of the final rule. You can make the best choice for you out of those three options as long as those three options are available. We still expect Medicare CQMs to be discontinued at some yet to be determined future year. Let's face it, it's still a dynamic system, and Medicare can introduce new methods, eliminate any existing method, and or make major changes to any method at any time in the future. Under this option, it still makes most sense for you for 2025 to engage a competent qualified registry vendor who will help you with your Medicare CQMs, converts you to MIPS CQMs when ready, and converts you from MIPS CQMs to ECQMs when ready, if ever ready. Now, in the final analysis, a competent qualified registry vendor, such as Mingle Health, is a great choice and a great preparation for any of the futures Medicare creates in the final rule for the quality payment program for 2025. So we hope to see you soon and to help put you on the path to your best possible quality performance metrics.